everybody for joining. All right, so by way of introduction, John Shrippa, president and founder of Unity Bands. Thrilled to have two guest speakers tonight. We have Keila Strick here and Caroline Williams from the Freed Center for Advancement of Potential out of the Charlottesville, Virginia area. So without any further ado, guys, I'll turn it over to you. Thanks for joining us tonight.
Yeah, thank you so much for having us.
All right, so let's go ahead and get started. So, like John said, my name is Caroline, and I am one of the clinical co-directors at FCAP alongside Keila. I lead the flagship clinic out in Crozet, which is about 30 minutes outside of the city of Charlottesville. It's also where I live. I started off at UVA, and I was actually an intern at FCAP, and I went on to physical therapy school. I got my doctorate in physical therapy from VCU. And then through experiences after graduation, I really realized that my love and my passion was working with and advocating for older adults. So I went on to get my clinical specialty in geriatric physical therapy. So that GCS stands for Geriatric Clinical Specialist. And then I also went back to VCU for a second degree in gerontology, which is essentially a holistic study of aging.
And my name is Keila Strick. I am a co-clinical director of FCAP as well. We have a second clinical location that's within the Student Health and Wellness Center at UVA. I was also an intern. Caroline and I were both part of the inaugural intern class of FCAP in 2016. We have both gone on to get our doctorates in physical therapy, and I'm also a certified strength and conditioning specialist. But we both practiced for a little bit in a more standard model of care, and realized that really our heart and passion was in this model that we originally learned from within FCAP, and have since returned to grow and expand the model that we're about to talk to you about today.
Yeah. So what Keila just described, how we were both in a traditional insurance-based healthcare model, and really we're not satisfied with the quality of care that the client was receiving, but also the quality of care that we were able to provide us as clinicians in this insurance-based model led us back to our experience in undergrad and with FCAP. And also, as Keila said, our goal is to spread access to the idea that this model is possible. And our goal is to make organizations like FCAP the rule instead of the exception. So let's back up for a second and talk about what is health. So health is defined by the World Health Organization as not merely the absence of disease, but a state of complete physical, mental, and social well-being. It's worth noting here that health should be understood as a resource for everyday life, not merely the objective of living. So health, as you know, is a fundamental right of every human being. And therefore, the quality, the accessibility, and the availability of health and health promoting resources are not merely a medical systems issue, but a humanitarian one. So let's create some definitions. When we talk about intellectual and developmental disability, how are we defining that today? So 1 in 6 children in the United States have some type of developmental disability. This includes ADHD and learning disabilities. The definitions of intellectual and developmental disabilities, or IDD, they can vary between states and also federally. So we're going to define IDD here in general, practical terms. IDD refer to 2 disability groupings. So developmental disability is this broader umbrella term, and it includes, but is not limited to, intellectual disabilities. So developmental disabilities are a group of conditions due to a delay or an impairment in cognitive ability, physical functioning, or both. Because of the diversity of ability under this umbrella, not all developmental disabilities are considered intellectual disabilities. Intellectual disabilities is, however, the most common developmental disability. So, as with most things in life, intellectual disabilities are on a pretty wide spectrum. The disability can be mild or it can be severe. So, 85% of people with intellectual disabilities have a mild form of intellectual disability, and it actually might be pretty difficult to identify in everyday life. And while this might seem to help with the idea of inclusion, it can actually cause additional problems, such as a lack of access to resources or accommodations, issues with employment, and even problems with law enforcement due to being misidentified or misunderstood. So, with that being said, let's start here. You're probably familiar with the idea that exercise is good for your health. But what does that really mean? So, on these physical activity guidelines from the Office of Disease Prevention and Health Promotion within the Health of Human Services, you can see a list of evidence based benefits to exercise. Of note, there's a lower risk of cardiovascular disease and cancer as one ages, improved cognition and quality of life, and improved bone health, as well as improvements in psychological health as well. And for all of these disease processes listed above, there is between moderate and strong evidence supporting exercise as a means of treatment. So, exercise is medicine, but how much is enough? The CDC and Health and Human Service recommendation is described as at least 150 minutes of moderate intensity exercise per week. And the benefits actually increase as you near 300 minutes per week. And at least two of these days should be strength training. And it's worth to underline here, these recommendations apply to all adults, regardless of physical or intellectual ability. So, reviewing these CDC recommendations of at least 150 minutes of moderate intensity exercise per week and 2 strength training days, only 30% of the general population actually meets this criteria. And then when you're looking at the adult population with intellectual disabilities, this number drops even lower to 9%. Only 9% of adults with intellectual disability reaching this minimum exercise criteria.
I would say that 30% is definitely problematic, but 9% is a little bit jarring. So.
Definitely. And we can see this reflected in the struggles that adults with intellectual developmental disabilities have health-wise too. So, according to the CDC, adults with disabilities have a 58 higher rate of obesity than adults without disabilities. Adults with IDD face challenges related to healthy eating, maintaining weight, being physically active, and they also experience 3 times the risk of heart disease, diabetes, stroke, and cancer as compared with the population as a whole. So let's talk about what those barriers are to accessing the benefits of exercise. So we're starting small and then we'll get big. So starting small at an individual level or a family level, there are comorbidities and there's concurrent physical health issues, right? Just with any of us. There also can be some issues with command following ability, being able to follow a structured program or exercises that require attention to form. Issues with intrinsic motivation, if there's anxious or aggressive behaviors exhibited, limited awareness of the benefits of exercise, right, at an individual or at a family level. We also see this in healthcare professionals, unfortunately, sometimes, as well as a limited understanding of safe exercise at that optimal intensity to really reap the benefits. Oftentimes, we see folks exercising at too low of an intensity, as well as personal economic constraints too. And so these individual barriers and considerations are compounded by these ableist biases. Ableist meaning discrimination on the basis of physical or intellectual ability. These ableist biases that are pretty insidious in our society. They shape our funding structures. They shape our policy. They shape our research and populations represented in research, as well as accessibility to equitable programs.
Our model was really born with the hopes to overcome the current limitations that Caroline has just outlined above, and providing high quality exercise programming for all people is really our primary goal. So we are the Freed Center for the Advancement of Potential, named after our founder, Barbara Freed. Um, FCAP is short for the Freed Center. We believe that health is a fundamental right of every human being, and adults with intellectual disabilities have the right to access the psychological, social, and physical benefits that exercise really provides. So you can see our mission statement here. Really, our primary goal is to help people with and without intellectual disabilities, and we function under a medical fitness model, which I'll explain a little more in these next couple slides. This is a picture of John Freed. He is the inspiration behind our current model. He is the son of Barbara and Mark Freed and was born with an intellectual disability where it was severe enough where numerous doctors recommended that his parents opt to institutionalize him. He didn't really have, it was thought that he didn't really have a high potential to function within society. So his parents were resistant to accepting this prognosis and sought other avenues of care. John became ultimately a celebrated international Special Olympic tennis champion, a four-time medalist, and physical activity, exercise, and tennis really became outlets for not just John but really his whole family. He was able to accomplish these goals despite some of his physical disabilities, one of which includes monocular vision, which essentially eliminates your ability to have any sort of depth perception on a court, which is just absolutely incredible. And ultimately, it became clear that, like many individuals with intellectual disabilities, the physical needs of this population are too frequently overlooked. And as you might have guessed, it tends to be very difficult for the intellectually disabled population to exercise independently. Safety and direction within a fitness setting is one thing, but they also have many structural comorbidities and are unable to independently implement a properly designed exercise program. So, with all these factors in mind, that's really where FCAP was born. And we love our model because the benefits are twofold. One being using or working with UVA students allows for a very cost effective, high quality one on one model of care that helps not only with like short term needs, but really the emphasis is on long term needs. And the students really benefit from this model as well. They're all highly motivated and they're very eager to have hands-on experiences where they're able to then apply these hours of experience towards their healthcare, their pre-health track, whatever it might be. So physical therapists, physicians assistants, occupational therapists. We all need hours to then apply to grad school, and this is a really good outlet for them. We've learned from the success at our clinic, our flagship clinic adjacent to Innisfree Village, that this model is worth expanding, not just to benefit the ID population, but really all populations in need. So 99% of our alumni network, we've had about 75 interns go through this program, will go on to enter the healthcare field, becoming physical therapists, physicians, PAs. One of the main values we try to instill is not only inclusivity, but also anti-ableism. And it's really important to not just create an inclusive environment, but really to be actively anti-ableist. Our society is implicitly ableist. We see this in policy, as Caroline mentioned before. We see it in the built environment and the subtle messaging that does not support equal rights, interests, and access for adults with disabilities. This is prevalent in many areas, definitely healthcare included, and fitness settings, where the appearance and performance of the physical body is often equated with someone's worth, and it really ends up affecting their care. It is important to the mission of FCAP to not only create an environment that appreciates and respects all clients, but to challenge students to take what they've learned at FCAP into the world by recognizing and calling out ableist practices and also modeling the type of clinician that the world needs more of. Thank you for listening to our presentation. Please don't hesitate if you have any questions or comments. We are happy to share and answer.
All right, I'll get it started. So how do you guys, so can you explain the collaboration that you have with the UVA students? Like, how do you find the right students? Are they coming from a particular major? How do you get them on the right project?
We work with the kinesiology department in particular, knowing that the majority of every graduating class is on a pre-health track. There is a certain hour requirement of hands-on opportunity, and Charlottesville, like many other communities, are really lacking in high quality hands-on opportunities for undergraduate students. So we have both taught within the kinesiology department. We teach a course that is an elective course within the kinesiology department called medical fitness, service learning and medical fitness. So it's kind of the starter to then selecting interns from each. We teach it every semester, so from each class, and we've really ramped up our marketing efforts of getting other students involved within the last couple of years. I mean, when we started, it was really nothing and pretty poorly organized, but we were still, like the other people in our class, we were just captivated by the experience because it was just so unique. And it's especially special when you have other experiences to compare it to, where you're like, okay, I'm really just wiping down tables, or I don't really get a chance to be actively involved. But in this one, we try to really prioritize education and active involvement.
Yeah, and like Kayla was saying, so she leads the class at UVA, and it's the service learning and medical fitness. And as part of that, once a week, they actually get to go into the clinic. So for half the semester, they're going to the student health and wellness clinic, working with the UVA students. And their model is more of a students helping students. And then for the other half of the semester, they're coming to see me in Crozet, and they're getting to observe and shadow and also get to implement some of the things that they're learning in class in the real life clinical setting, obviously under intern and my supervision. But it's a really great way to almost do a dual vetting process. We attract the students that are really buying into this model and like what we're doing by the end, and they come on and work with us. And then we also get to challenge their clinical reasoning skills and their passion. So it ends up really being a great matchmaking process during that semester.
Awesome. Thanks, guys.
I have one question. Thank you again for taking the time to do this speaker series session for us. I just had one thing to follow up on John's. Sorry about that. So one thing to follow up kind of on John's question. You mentioned that your collaboration is largely with pre-health track students. I'm curious how you guys define pre-health, what kind of disciplines. I know you listed physical therapists and physician's assistants as potential examples. Are there any other disciplines within health that are covered within that band that are interested?
Primarily, those are the two main ones, with physical therapy being the leading avenue, but there have been numerous pre-med students as well as occupational therapy. So I'd say those are the four that we've seen, and then a couple that go into specifically or athletic training or exercise physiology.
Okay, very cool. Thank you.
Yeah.
You all think of any questions afterwards, Kayla included the link to our website. Feel free to drop us a line, and we will definitely be able to answer any questions you all think of in the future, and also to learn more about our facility. Yeah.
Yeah, we can share our contact with John to disseminate. But yeah, I mean, we're just really thankful for this opportunity. You all listening to us today, we are very clearly passionate about this model and what we're trying to do here, and getting to just speak on the topic that we care so much about. It just means a lot to us. So thank you for listening on a Monday evening at 7:30 p.m.
Yeah, ladies, really appreciate it. Taking the time not only just to do this talk, but just like the work that you do out there is really incredible. So I appreciate all you do. The only two dates I have for you right now are our next two speaker series. So Monday, August 26th, we have Fred Delp. He's the executive director of the National Alliance on Mental Illness, also known as NAMI, part of the Anne Arundel County chapter. That's here in Maryland. And then on Monday, September 30th, we have Juliet Bui, who's the director of the Office of Minority Health Division of Policy and Data. That's with the U.S. Department of Health and Human Services. The time for that is to be determined. It's going to be different. It's going to be like a daytime speaker series. So be on the lookout for when we secure that time on September 30th. Other than that, I think that's it in terms of announcements go. So everybody have a great night, and thanks for joining us.